So, thank you very much. I enjoyed all these lectures very much, and that was voice of my nutritionist's heart. So please, it is time to your questions. Yeah, please.
Hi. Hello, thank you very much for your amazing presentation. I think it's such a needed work. My name is Maria, and I'm working as a critical care step-down dietitian in the UK. And I work with inpatients, outpatients after they are discharged from intensive care. And my first question is,
Please stay calm. Yeah, stay calm and quiet. Yeah, please.
I'm aware that you mentioned about the 4,500 calories that some patients get, but sometimes when I have like very little patients and they are receiving around 40 kilocalories per kilogram, I question myself like, is there like any harmful like amount or like so my question is, from your experience, would you continue like providing and increasing energy up to the moment that the patient is gaining weight?
Thank you for that question, and thank you for your patience. So first of all, we know that in intensive care, there's this cutoff, like 4 to 10,000 kcal. This is when the complications come. Over the entire hospital stay, we don't really know where this number is, where the complications will come. But we have many data to show that when you have an adequacy which is lower than, let's say, 70–80%, your patient is going to be in trouble. So we really think that you should continue over the whole trajectory of care to be in a safe zone, and that will probably be, but we have to discover what that is, but at least it needs to be, 85%, this is what the protocols tell, 85% of the needs, and you use whatever is needed. It's a therapy.
Yeah, and maybe to add to that for the post-ICU phase, I think maybe we have to separate calories and proteins. So what for me was striking to see, if you look at protein metabolism in ICU and you see the production of urea as maybe a marker of not being able to handle the proteins, the urea genesis, well, the association with the high UCR, urea creatinine ratio and hazard, is probably only found in the first 10 to 14 days of ICU stay, suggesting that when you overload yourself or your patient with proteins in a phase that is not, well, let's say severely anabolic resistance any longer, that maybe you don't use all the proteins, but you don't have the risk of increased mortality. So it's very phase specific. And also the overfeeding in the early phase is due to the fact that when you normally start eating, you will stop breaking down your tissues because, insulin will stop the production or the breakdown of glycogen, for instance. But in ICU, due to this catabolic response, you see non-inhibitable endogenous energy production, so not stopped by feeding or insulin. So I think the risk of overfeeding both energy and proteins after ICU discharge when the patient is recovering, and moreover when you can start to do exercise, because exercise will also reduce insulin resistance and will promote the anabolic signals for muscle protein synthesis. So there is a lack of data there. So I agree that maybe you are concerned, because also in the Minnesota Starvation Project, there are some indications that some of those healthy males develop myosteatosis during the recovery phase. So, and how to prevent this, we don't know. There are new medications coming up, also in the context of GLP-1 medication to lose body weight, and we want to prevent the muscle loss there. So I think in a few years, maybe we'll also have like medication that will help us to lose only fat mass and not muscle mass. But it's true, but I think personally slightly overfeeding the patient and giving more energy and protein to the patient because they have to build up new muscles and tissues, of course then you have to go over your resting energy expenditure, otherwise you will never build new tissue. So I'm personally not very afraid of overfeeding after ICU discharge.
And if I can give an example, so we have a study also to tackle malnutrition. One of our first patients in the study, the dietitians came back and they said, The study patient is drinking 8 oral supplements a day. Should we stop him? Because it is above the protocol. We didn't think about that when we designed the protocol, you know, because the big challenge is underfeeding. But what do you think? Would you say, no, you can't, you have to stop eating? I don't think so. So I align with you that both from a physiological and a practical standpoint, if the body is ready and the people and the patient can tolerate it, please let them have it. And if they're not able to do it by themselves, we will help them.
And we had the answer in the Minnesota semi-starvation study in the recovery phase, yeah, that Professor Zanten talking about. It is about 4,050 kilocalories per day to gain their weight. Yeah, so we have answer. So take these patients, eat and take ONS as much as they are able.
Thank you.
Because 35 kcal per kg per day, if you do that math for your own body weight, 35, that's not so much, you know, that's not 4,000. But maybe for you, but not for me. That's the surgeon getting the internal medicine.
The surgeon also.
I have another question, if that's okay. It's regarding the muscle quality that Dr. Van Zanten was mentioned. Is there like any way that us as a clinician we can assess and monitor like the quality of the muscle that our patients are gaining? And are you aware of any nutritional strategies that we can use to promote that high quality?
Yes, you can use very simple clinical tests like hand grip strength, sit and go, 6-minute walking test. What is feasible and possible to do in your context. And maybe that kind of, it's also in the discussion of frailty and sarcopenia, of course, should we only focus on muscle mass or should we also go for muscle function? And I think if you look like in ICU-acquired weakness, the weakness in the legs is more severe than in the arms. But for patients to be independent and be able to have a normal daily living, well, the performance of the legs is very important. So it's not only mass, it's especially also function. And we don't have so many studies focusing on function, and I think we have to do more work there. So we have to learn what are the interventions that not only lead to preservation or regaining muscle mass, but also especially regaining muscle function. So that's an excellent question.
Okay. Thank you very much.
So we have some questions from online. What is the best nutrition intervention to prevent muscle weakness, especially respiratory muscles, and help warning of ventilator? Is this anything specific about type of protein intake in the ICU?
Quite interesting, that very good remark, because when we talk muscle, we think about limbs and hand strength, but your diaphragm, your heart, is also a muscle. So to answer the question, maybe you have a better response, but I think there is no, straightforward, this protein is for the diaphragm, this protein is for the heart. I think we should really stick to our ESPEN guidelines that tell you between day 4 and day 7, you should be at 1.3 gram per kg per day. I think this, just deliver it, the patient will use it, and this is until now still the best proven strategy.
Yeah, maybe one addition, I think the diaphragm is a muscle that's active in ICU patients in the bed when they're on supportive ventilation or breathing normally. So there is no immobilization in the diaphragm unless you sedate the patient or paralyze the patient for a prolonged time. And then you will see atrophia in the diaphragm. Moreover, mitochondrial dysfunction in diaphragm muscle has not been proven. So it seems to be that the diaphragm is a different muscle and also probably the myocardium. So we have to separate peripheral muscle, skeletal muscle from other organ systems. So that's something to consider. And then with respect to the magic bullet, what should be the optimal composition? Personally, I don't think we have to go very high in specific amino acids. So we did studies with arginine, we did studies with glutamine. We're not very successful. More and more, I believe that we need some kind of balanced amino acid spectrum. There's this idea that you can have maybe rate-limited amino acids. So when one is specifically very low, you miss some building blocks to make the proteins. So maybe we have to provide a more mixed, balanced amino acid composition. That's also very relevant if you consider like the plant-based proteins, because not all the products with plant-based have the same quality of especially essential amino acids. So that's something we have to study in the future. But, well, during recovery, we don't know. In other patient group, we know the effect of leucine or maybe downstream factors like HMB or other specific amino acids. But I think the proof in ICU to use specific amino acids or compositions that lead to a better outcome, well, this is very limited information. So we have to do more work there also.
So the second question is, I think, regarding to our microbiota. What is the role of fiber in post-ICU recovery?
Well, I think the real answer is we don't know. If you look at the microbiome, it's severely disrupted, but there is very limited information. Actually, one of my PhD candidates is doing a study now. We follow up patients for 1 year because we don't know exactly when this disruption, this dysbacteriosis in the microbiome is resolving or going back to normal, or does it persist for a year, and is there a difference in patients with ICU-acquired weakness versus those with a normal performance? We don't know, we don't have this information, so we have to study this. It is very likely that, well, at ICU discharge, patients have severe dysbacteriosis, and I personally believe the only way to help your gut microbiota is by feeding enterally. And they can use fibers we cannot absorb or metabolize as humans, but the bacteria can do this. So prebiotics and probiotics. There is a little bit of fear for probiotics in ICU because we had the Propatria study, the pancreatitis study showing like increased mortality. But if you look at all the data of probiotics, even in ICU, it seems to be rather safe. So maybe not in pancreatitis patient, this was also delivered in a post-pyloric fashion in a new product, never been tested before that study. So I think during the recovery, and I like this idea of Paul Wishmer, he's stating, well, we have to reseed or resort the lawn, yeah? You know, it's a catastrophe in the gut, and maybe we have to provide new bacteria, probiotica to have a new lawn in the gut, you know? That's a very challenging concept. But we have to do more work to do studies and to see whether this is helpful also to recover from PICS, from the post-intensive care syndrome.
So I think that we can see it on GI dysfunction after discharge. Yes? It's this point of view. So, ladies and gentlemen, thank you very much for your attention. And I'd like to thank you for all our experts and for Nestle Health Science for organization of this symposium. Thank you very much.
Thank you, Mr. Chairman.